Everyone, welcome. Thanks for joining us on this episode. Shaun Brewster and Bodine Ledden with you once again. Bo, we are fair way into our series of podcast episodes here, and recently we had a chat with one of our long-term listeners, and it's not often that we get to speak to people who listen to the podcast and give us some real-time feedback in person. So we both wanted to give a little bit of a shout out to Pleasure Thompson, who joined us on one of our manual therapy retreats recently and tells us that she listens to us every week in her very long commute through central Queensland. And firstly, Pleasure, apologies for our voices and droning on in the background through a big chunk of your life. Hopefully you found it useful, but it's really nice to hear from people who are consuming our content and putting it to good use. And so thanks for listening. And if anyone else out there is a long-term listener would like to, send us some feedback, send us their, we'd love to give you a shout out as well. Pleasure, and anyone else who's been listening throughout the course of our podcast history, which has been a little while now.
Yeah, it's always so nice to hear when you go to a course and someone says, "Oh, I've been listening to your podcast," and you go, "Oh, you guys listen to that." Um,
Yeah,
yeah,
we just
no,
do it
it's
for
really
ourselves.
nice.
We literally have no idea if anyone's listening at all. So thanks for anyone who does. And actually, when you look at the stats, there's people all over the world. So that's really nice. But yeah, feel free to give us a yell, guys, if you've got any feedback for us. We'd love to hear it. So, Bo, today's topic is something you and I often find ourselves talking about. It's something that would be very easily to fall into a rant on. So hopefully we can control ourselves today. But this idea of therapists who believe they fix things. And I'm going to come out and say, we don't fix anything in clinical practice. What do you reckon?
Yeah, 100%. And that's it's an important thing to grasp because it's for patients coming to you, I need my back fixed. I need my heel pain fixed. I need my shoulder fixed. Well, I mean, I would love to be able to be a mechanic and go in there and literally fix something, but that's just not our bodies are far more complex than that. It's our bodies are incredible healing machines, but they can be influenced by a number of different things, such as stress, anxiety, worry, fear of movement, deconditioning, nutritional factors, lifestyle factors, behavior. It's we can't fix all of that, and that we know that how complex pain is. Not everything is a mechanical based presentation. And so it's not as if that whole narrative that something's out of place, something needs to be pushed back in, or something's short, it needs to be lengthened. That's just not the case. And if we thought of it that way, well, then all surgery would always work every time. But we know that people sometimes don't get better from surgery. And so, yeah, we don't press on areas and just fix them. We can have pain relieving effects that are associated with that, but it's not necessarily a fix.
I think that is, and I often get caught in this idea of describing the human body like a machine, and it's a nice analogy to use because a machine has different processes in play at any given time, and those processes can be influenced, and that can affect the outcome of that machine. So in that way, we are a bit like a machine, but we are way more sophisticated and complex than any machine that's ever been created by humankind. And so we have to give credit where credit's due to the human body in the things that it can do without our influence. And so a lot of the time we see patients will come to see us, this classic example of practitioners who have long waiting lists, and the patients will be waiting. They're like, "Oh, I can't get you in for 6 months." And you go, "All right, well, I'll just wait." And the beauty of a long waiting list is if you just wait 6 months, most things get better by themselves because the human body has an amazing ability to heal itself. So sometimes the waiting list is the solution for the patient because if they just hang on, they'll often get better anyway. That's one thing, right? The other thing is, rather than looking at the human body like a machine, maybe we should look at it a bit like a garden, right? And so as a practitioner, we're the gardener. For that plant to grow into a huge tree, into whatever it's going to turn into, it needs to want to, for one, and it also has to have a whole range of different components all working together at the same time. So as a practitioner, we come in as a gardener, we might till the soil, we might add some water, we might sprinkle some fertilizer. All of those things can support growth. But unless that plant is healthy enough to actually grow itself and has the intention of growing, well, then it's probably not going to. And so there's nothing that we do as a practitioner that will fix the human body, that will make the plant grow. We create opportunities for progress. We create opportunities for change. And then the organism has to go through that process, has to create that change. And those things that we do might be improving some physiological function, right? That might be improving or encouraging greater conductivity of a nerve. It might be assisting with the promotion of healthy blood flow to an area. It might be improving reporting between peripheral and central components of the body. It might be improving through exercise. And again, this is not us, this is the patient, but us prescribing exercise. The patient might improve tolerance through tissue by improving strength of that tissue and different structures in the body. These are the inputs, but really they are just guidance. They are moving the person towards a situation where they have the physiology that is appropriate to then do the things they need to do to create the change they want. And so, this might be all semantics and words, but I think it's important for us practitioners we've got to stop saying things like, oh yeah, I can fix shoulder pain, or I know how to fix your patella tracking issue, or I know how to fix your ankle sprains. No, you don't. You understand what those pathologies are, and you understand some things that you can do that might reduce pain and advice that you can give to the patient to move towards health. But the patient's body fixes the problem because it's a living organism that has the ability to do that. We are separate. We are the gardener that provides the ingredients for growth. That's it.
Yeah, I like that garden analogy, because it all comes back to homeostasis, right? This term that we learned in undergraduate studies. And homeostatic balance. If we've got a stressed garden, for example, that it's poor nutrients, there's poor soil, there's poor sunlight, a number of these different factors. Well, that's going to increase stress. Versus if we've got a healthy environment, good nutrients, good soil, good environment, stress levels decrease. And if there's this homeostatic balance, well, that's when the body does its best at repairing itself. But if we're in a hypervigilant state, highly stressed, highly anxious, well, we're always on guard. Our nervous system is trying to protect us at all times. And so that's when our nervous system sensitivity may be far lower. So, much higher sensitivity, I should say. And so it's easier to stimulate a protective response. And so in that environment, if we're trying to run away from danger, well, we're not going to be in that state where we can start to the parasympathetic state, where we can start to repair and recover tissues and synthesize new cells and all sorts of different homeostatic functions that go on, physiological functions. So it's about getting that balance right. And what we do in clinical practice is one way to do that. If we can educate our patients about what's going on, that can decrease some stress, some anxiety, some worry. It can promote movement and exercise. Manual interventions are another great way to reduce stress and anxiety and have a feel-good effect, upregulation of endogenous opioids, decrease sensitivity of tissues. Okay, and so this is all aiming to sort of neutralize that homeostatic balance. And so if we can use that to leverage on to the next step, which was getting people moving, getting people more comfortable with exercise, sort of challenging how far they can actually go and what they can do. I think that's the importance of what we're doing. We're not the ones that are fixing them. We're the ones that are guiding them and assisting them along the way.
Definitely. We're basically just kind of giving information about which direction to go and then shining a light in front of them to say, that's the direction you want to go. Off you go. Here's the tools. Here's the information. We've supported you as best we can by reducing inhibition to movement, by reducing fear and apprehension. We've supported you by reducing sensitivity. These are just symptom modifications essentially for you. And now you've got to go and do the work. And this is where it really is just a language conversation we're talking about here. It's like, we've got to stop telling our patients that we can fix them. It's nice, right, to be able to say that. And it's nice for the patient to have that belief. But at a certain point, that creates reliance on you. And that will eventually backfire. because there will be patients that will just wholly rely on you, not want to do any work themselves. In fact, we've all got them. We've got patients like that. And then at a certain point, they won't get better. And then they'll be looking to you going, well, maybe he or she doesn't know what they're doing. And why haven't you fixed me this time? You fixed me last time. And so it's a difficult one, because what a powerful thing to be able to say, yeah, I can fix that for you. But it will eventually come back to bite you on the butt. And maybe the language could be something like, I understand that presentation quite well. I know some things that will probably help reduce your pain for you. And I know how to get you to where you want to go. Would you like to participate? Would you like to be a part of that? Would you like me to help you get to where you want to go? That kind of language is empowering, and it's truthful. It actually describes what we do, rather than makes a claim that would be nice to be able to say, but really isn't based on fact.
Yeah, and that's that whole building trust, rapport. We've always got to consider contextual effects. We've always got to consider the placebo effects as well. And so if a patient's more confident that you're the master, you're the guru, and they will make you feel better after this treatment, well, fantastic. They're probably more likely to have a better result. But the opposite to that is true, that if they go to the guru and the master and they didn't make them feel better, they go, oh, well, my pain must be the worst. That, it must be the worst one that there ever is. So, that can have the opposite effect there as well. So, the psychological impacts of are so important. And I think that's why, there's some fantastic practitioners out there who are just really great communicators. They're great rapport builders. They create this great therapeutic alliance with their patients. And yeah, they get fantastic results, but it doesn't mean it's because they use this specific technique. They did a cross fiber technique as opposed to a longitudinal technique. They followed this specific protocol with these specific techniques, because those techniques probably don't really matter that much. I mean, people ask me all the time, well, what techniques are best for shoulder pain? So, well, what makes it feel better? I mean, it probably doesn't really matter. Like, does it feel better to mobilize it? Does it feel better to massage it? Does it feel better to needle it? Does it feel better to exercise? Well, which one do they prefer? Which one are you better at? Which one works out best at the end of the day? Because if the way that I treated someone might be very different to someone else, but we might both get very good results. Or one might get better results than the other based on the patient's preference. So that's what's tricky. Like, if it was purely as easy as fixing someone, then I should be able to do one thing, and then Shaun, you'll be able to do the exact same thing and have the exact same results every time. But it just doesn't work like that.
That's right. Yeah. And look, we've talked about treatment protocols before, right? Like, people use, this is the protocol I use for shoulder pain. I hit this trigger point here and I do this mobilization, this stretch, and it fixes the problem. Well, if that was true, to your point, then why does that same patient go and see their chiropractor and get some results? And then they go and see an osteopath and get results, and then go and see their exercise physiologist and get results. It can't be true that the thing that you did was the solution. I think the thing that is true is the thing that you did, or the thing that any of them did, created some change in sensation. The patient felt better, then they moved better, and then they were better. And if we're talking about chronic pain presentations or longer standing presentations where there's more than just a sprain, like you haven't just fallen over and hurt yourself, there's more complex things at play here, then there's 1,000 ways to skin that cat. There's lots of ways to get to a solution, but none of them are the exact thing that we do clinically. They are the tools that we use, the way that we communicate, the confidence that we have when we communicate with them, the trust that we build, the rapport that we have, the belief that the patient has in us, the environment we've created, and the list goes on and on and on and on and on. And so how you get from A to Z, there's 1,000 different pathways to get there.
Yeah. And that's what I love treating acute injuries, because they always get better.
Yeah, my favorite too. Yeah.
I mean,
sports injuries, awesome.
yeah,
Throw them at me. I can help you with that for sure.
Yeah, like you've got a sprained ankle. I can be pretty confident that you'll be back to sport in 8 to 12 weeks in most cases.
Regardless of what I do.
Yeah, exactly. It's sort of like, I'll give you some advice, but I know that there will be physiological processes that will that will, we'll have to have the reduction of swelling. We'll start to get some increases in range of motion, as there'll be some stiffness. Then we've got to start to gradually build you up to those, getting back to running, hopping, jumping, change of direction, all of that sort of stuff that can support. But at the same time, I've sprained my ankle in the past many times and never done anything about it, and it's got better. And so, did I need to go and see someone? Well, I'm not a high performance athlete, so probably not. I know it's going to get better. Some people will have persistent pain, and there can be numerous factors that are associated with that. But we know that, in acute injuries, right, there will be a time frame that's typical of plus or minus a couple of weeks here and there. But it's the chronic pain cases that they can be trickier, because now it's not so much something that's wrong with their tissue. It's more so there's some changes that have occurred in their nervous system and their beliefs about their pain, their expectations, and these learned response. Remember that pain is a learned response, and the more that the longer that it's there, the more efficient those synapses become. So we have changes that are occurring in the brain. And so that can be a harder thing to change. It's sort of like trying to break a bad habit. These are long-term things that occur. And by simply pushing on a spot won't create those changes. It will create some modulation of symptoms. And it's about doing this over a period of time in combination with other things, that's where you might see long-term changes.
Yeah, it's look, speaking of breaking bad habits, I keep coming back to this idea of, faulty language, right? Which is the idea that we can fix things. But there's also this extrapolation of that, which is you need maintenance. You need maintenance treatment. You need to come and see me on a regular basis so I can maintain your thing, or just come in when you have some pain and I'll do a little top-up session for you. And now that's a really nice business model. Don't get me wrong. If that's your business model, and I know a lot of people practice that way, it's a nice way to get return patients. And for the most part, the patients will come in, receive the service, feel better, leave satisfied. So you can't argue with that to a point. If we were going to look at it from truth and clinical evidence, we would look at that probably differently and say, well, if you come and see me regularly so I can maintain your health, maintain your function, that's building a reliance on the practitioner. That's saying to the patient that you can't get better, that you will not get better without me. And I think that's a potential problem. We did an episode a long time ago on over-servicing patients, and I think that's the underlying problem with over-servicing, with over-treating, or with treating unnecessarily. And so beware any practitioner that says to you, I'm going to need to see you every second week ongoing. And if you'd like to pay for the year in advance, I'll give you a discount, right? Because they're locking you into a plan that they can't possibly know how your physiology will respond over the course of that year, 6 months, 12 months, even 3 months sometimes, depending on the presentation. And so we've got to be cautious. And I think I'd like to encourage audience to consider what is their business model and what is their clinical model. And if there's a clash of philosophies there, maybe reconsider. There are other ways to build a profitable, busy clinical practice without teaching your patients that they need to come and back see you on a regular basis for a top-up or for maintenance treatment, because there's no physiological phenomena to base that belief on, And so then I'll keep ranting about this for a second, but if the patient then says, but I feel better when I come and see you every month, every 3 weeks, every 2 weeks, therefore I should keep doing that because I want to keep feeling better. Well, then we ask ourselves the question, is this the best use of your money, right? Because if you're going to spend that amount of money, is there something else I could give you, some advice, some direction, something you could do for yourself that would also make you feel better, or that would give you a better understanding on how to manage those symptoms when they arise so that you don't need me? Because there'll be a time when you can't get to me, when I'm too busy, or I don't have the time, or I retire, or something happens, or you're not available, and you'll feel stuck and you'll feel like, I need to go and see Bo. I need to go and see Shaun. I need to go and see whoever to get this solution. When I think our ultimate goal should be to empower our patients with knowledge and information and understanding about their own human bodies so that they can provide their own solutions. Our job in the beginning is to give them those sensory changes, those symptom modification experiences And then gradually over time, as appropriate, sometimes that's a faster timeline or slower, but gradually over time, we then remove ourselves from the equation to the point where they don't need us. And then something new happens in the future. Sure, come on back. We can start that process in a different direction for a different problem. But the reliance factor based on maintaining or top up or, whatever term you want to use for that model of clinical practice, I think is part of the reason why some of our fraternity, of practitioners, our group of practitioners, get a bad name for, just stringing patients along. And I think it's why you and I do this, Bo, when patients come to see us and they go, well, when would you like to see me again? And we say something like, actually, I don't think I need to see you again. Or at least, depending on the presentation, I don't think I need to see you again. Here's the advice you need, off you go. And they go, hang on a second, what? You don't, it's almost like a nice surprise. I think that should be the commonplace thing. And then if there's a physiological, pathophysiological need to see them again, it needs to be reasoned, clinically reasoned, and then laid out in a truthful, upfront way to say, here's what I think you can expect. Let's see how you go with that, rather than locking it in 12 months in advance, whatever it might be.
Yeah, I mean, I like to have a little bit more, I guess, I'd like to see my patient in a shorter term, and then to get them on the right track, manage symptoms, particularly when it's a little bit more severe, the high levels of pain. I would rather see them that little bit more in the short term, but then I'll say, hey, I'll check up on you. I'll send you a message. I'll give you a call in the next week or so. See how you're tracking, and then from there we can see where you're at and book something in if needed. Otherwise, you've got the skills and the tools to manage this yourself. But yeah, and I think it's always going to depend as well on the type of practitioner that you are as well. I guess we're probably looking at it through the lens of we've got patients coming in with acute or chronic pain and they want to get that pain under control, as opposed to patients that are just coming in because they want recovery from sport, or just a de-stress, whatever that may be. It will depend on the type of practitioner. But I guess sort of where you're going, Shaun, with I was chatting to a colleague of ours last night, and patients that would call up and say, oh, when do I need to make my next appointment? And they'd say, oh, well, your x-rays haven't came through yet, so we can't figure out your treatment plan yet. And it's this poor patient will be sitting in fear, thinking, oh, I wonder what's wrong with me. And so that's that creating that dependence and the fear that there's something wrong with me based on my scan, that I'm out of alignment, I'm structurally unstable, I've got a high risk of getting injured if I don't maintain consistent treatment several times a week for the rest of my life. And I think that's a real problem. So yeah, it can go either way, but also I think if we've got these really long waiting lists as well, and there's a 3-month wait list, for me, if I get a new patient, I would say, hey, I need to see you next week because we've got to follow up on this and see where you're at. And if I'm booked out 3 months in advance, well, I don't have room to move them to put them in. So I think it's always going to be on that case by case basis. But that sort of every week, every 2 weeks, ongoing. I don't know that's a real fix for the person, or if they need it to top them up. It's probably just that they like going to see you.
That's right. And thank you for clarifying that even further. I think that's an important point too, because we don't want to offend anybody by saying that model of clinical practice is inappropriate, because there are some patients that want to come and see you on a regular basis and they feel better for it, right? That's different than relying on you for whatever it is, whatever the magic is that you do for them. And so this is particularly relevant to massage therapists, right? And I know a lot of different practitioners listen to this podcast, but if you're a massage therapist, it's very easy to fall into that trap of, I need repeat bookings, I need the same people coming through the door all the time. That's one model of care, right? Like that's one model of clinical practice, or practice, I should say. But if you're looking at it from a clinically reasoned perspective, it's like, do they need to come back? And this is, I think, also a flaw in a lot of business models where practice owners will say, we need to increase your rebooking rates, and the best practitioner in the clinic is at 95% rebooking rate. 9.5 patients that come through her door, we'll be back in again. Well, okay, what are they doing for them? If they need to come back so often, what haven't they helped them? Haven't they given them the tools and knowledge they need to be able to move forward? Maybe that's a negative reflection of how they perform. Unless, of course, the business model is a nice experience. Patient comes in for massage, whatever modality, and the client probably might use that term rather than patient. Client comes in for a nice experience. They feel nice. They float out afterwards. Who doesn't love that? I love that. Bo, you and I both go for massages because it feels good a lot of the time. We might not have a problem to solve. And then there's nothing wrong with that model, right? But we have to decide, what type of practitioner are we? Are we providing a nice sensory experience, which is amazing, or are we trying to provide advice, guidance, physiological input to a human body to help move it towards a particular goal so that it doesn't need us? Because in an ideal world, humans shouldn't need us. We should be all healthy and well enough to be able to do what we need to do. And at a certain point in history, we didn't exist. So what did people do before that? Well, they probably just got on with it and got stronger and got over it. So, we have been, what we do today is very much a modern creation, a modern idea, because we've gotten smarter at how to influence the human body. And great, like it's useful, it's valuable work. And you and I are huge advocates for manual therapy and exercise and all the things that we do clinically. But you've got to decide, are you providing a nice sensory experience, or are you trying to move the patient towards health? Those two things can be sometimes together, but more often than not, they are two separate parts.
Yeah, that's right. And if you're looking at that from the pain modification point of view, well, then you should be looking at those treatments and thinking, are these progressive? Am I going anywhere? Or am I just doing the same thing every 4 weeks? Because if I'm doing the same thing every 4 weeks, what am I missing? Or what else do we need to add in? Or who else could we involve in this healthcare team? Because we want to have this progression forward. Versus the other model, which is fantastic as well, like for relaxation, decreasing stress, anxiety, improving sleep, the social connection, the power of human touch. All of these things are so valuable, and it might be that that's what that person needs, and that really helps to modify their symptoms. And so it's sort of, I guess, thinking about what we are trying to do here. Are we fixing them, or are we guiding them along the right pathway? Are we using our treatment to modify symptoms and allow our patient to progress forward, as opposed to my treatment fixes this problem?
Yeah, good. You highlighted a really important point there. It's I probably made a little bit too simple in my initial explanation that it's a nice sensory experience, or it's a movement towards physiological change that heals or changes the situation for the patient, right? But maybe there's a middle ground. And I think I've been pulled up on this one before. People go, but I see such and such patient and they've got chronic degenerative whatever problem. And we know that won't ever really get resolved. So they come to see me on a semi-regular basis and they feel better for it. So are you telling me that what I'm doing there is not providing a clinical intervention? It's just a nice sensory experience. Well, I go, well, no, that's the blurry bit in the middle, I think. That's where you've got a patient with a clinical problem. You're providing a targeted solution or targeted input for that patient that doesn't necessarily move them towards ultimate health goals. It moves them towards symptom modification to improve quality of health, right? And that's different, right? It's nice. It's about to give someone a nice sensory experience so they float out. But then there's that other bit, which is the person's got chronic, really bad osteoarthritic knees, and it just aches all the time. And so you might provide some manual therapy that reduces their symptoms in the short term. So they have this window of opportunity to live their life a little bit more comfortably, which is fantastic. But if all you're doing is doing that every 4 weeks, back to your point, Bo, which is, what else could we add to this? Could there maybe some exercise that we could involve here? Could we involve a nutritionist who could look at some supplements, some kind of dietary modifications that might be able to then unload some of the excess load on those joints, maybe improve some joint health along the way? Could we involve who knows what else to maybe lengthen or extend the effect of what we're doing with our manual therapy and prolong the effects of what they're doing with the other things they're doing in life, like exercise? So I think that approach still sits in the clinical intervention camp. It's not in the relaxation day spa massage space because the approaches we're using are clinically reasoned, providing we're also considering what else we can do. It's not just me, it's what else could we add to this?
Yeah, and I always have this debate with myself and with other people about, well, how specific do we really need to be? If someone's got pain, well, do we need to specifically target that area? I mean, that could be a part of their expectations that contribute to pain modification, or could we still have a pain relieving response by giving a full body treatment, for example? And I've had patients where I've heard their story and they've told me about their pain, but I say, it sounds like you're having a really tough time. It sounds like you just need a bit of a de-stress. And I'll just give them a bit of a general treatment. Amazing. And so maybe that's what they need. It's the same with exercise. Like you mentioned in knee osteoarthritis. Well, do we need to focus specifically on knee extension, knee flexion based exercise and calf raise? Well, that will probably help a bit. But so would just going for a walk. So would going for a run, whatever they can do, because remember where these pain modulation chemicals come from and where pain is coming from as well. Pain's a construct of the brain. And so whatever intervention that we do, any sensory input that we provide, that the interpretation of that occurs in the brain, along with the interpretation of noxious stimulus. All right. And so how we apply a different stimulus to our body will modulate the overall pain experience and the perception of pain, because that's important. Pain is a perception. And we know this we look at imaging studies where the pathology doesn't need to change for the pain to go away, and people can have pain in the absence of nociceptive input. And so pain is so complex, and that's why we can't put our finger on what specific intervention is the best for pain. Otherwise, we'd probably be all out of a job.
That's right. Yeah. That's such an important point, isn't it? Like this, and it comes back to what we were saying before. There's no one thing that is the solution. There are infinite solutions because they all provide different types of input to the brain that the brain might like. And it will be different from one person to another. And so that's why some things work for some patients and some things work for others. And so we have to consider that that we don't provide a solution. We don't fix the person. We provide input that the body perceives as noxious or positive. And ideally it's positive. And then the body responds in a positive way to that because it likes it. And then we get them to the next bit and the next bit and the next bit.
Yeah, because you hear this all the time, don't you? That people go, "Oh, I do this for my frozen shoulder patients, or I do this for my fibro patients,
Yeah.
or this technique works best for my hip patients." You go, "Huh? Okay, but like I do something different, and John does something different, and Sally does something different, but all end up modifying someone's pain." So is that the technique? Is that the fix,
Yeah.
or is there something else that's going on?
Yeah. But we see this all the time, right? Dry needling courses are a classic example of this. We have 20 people in the room, 10 of them laying on tables, probably half of them have got low back pain, and we do some needling to the low back. Half of the room probably gets up and goes, half the people with the back pain get up and go, that feels better. And there'll be a few people that go, oh, that was uncomfortable. I didn't really like that. Same intervention, same needles, same probably similar location of needling, same depth, same type of stimulation. But a percentage of that group will have a negative experience because they didn't like the sensation. Nothing to do with the modality. The modality doesn't have that power. It's the patient's perception of what it does, which tells us it's a lot about what's going on in the patient. It's also a big part about the confidence that we have when we deliver that, the way that we communicate, the way we make them feel comfortable, the rapport that we have. And then we have to decide, is this the thing for them? Well, on this particular day for this particular person, it might not be. Maybe you don't need me today. Maybe you need to go for a good walk. Maybe you need to go to the pub and have a beer with your mate and talk about your problems. Like that's a thing. That is actually a thing for some people in some situations. And so you wouldn't prescribe drinking beer as a solution to problems, but for the right person on the right day, a good conversation with someone that they trust in a non-threatening environment might be the thing they need. Maybe it's not the needle in their back, or maybe it's not that exercise, or maybe it's not that, elbow in the hip. It could just be something else. So I think us manual therapists probably at times need to get down off our high horse and not claim to be able to be the savior of all problems, and just recognize that we will play a role at times. Our role is probably not as specific as we thought it once was. But if we are using good decision-making processes, thinking about physiology, thinking about pathophysiology that we're being presented with, and the natural course of history and how we can support that along its trajectory, then I think we make better decisions.
Yeah, that's great. And we get asked those questions like, could you do this? Could you do that? And like, well, does it help? Great,
Yeah.
you can do that.
Does the patient, then I'd go with that. But consider all those other factors along the way. Yeah, good. Bo, have we ranted enough about this one?
Yeah, I think so.
I think so. We could go on all day. All right, let's call it quits. Thanks always and forever for listening to this podcast. We really do appreciate our listeners out there, and we're going to keep putting this out as long as you listen. So thanks again, guys. We'll talk to you soon.
Cheers.